Yet another NFL knee injury. Cedric Wilson. What happened? How did it happen? How was it diagnosed? And how it will be treated? Stay tuned to find out. Hey everybody, Dr. Chris, orthopedic surgeon and sports medicine physician. Welcome to my channel, your #1 source for information on broken bones and other things orthopedic.
That's a little doctor joke we like to make around here.
So yes, it has happened again. Another NFL player has injured his knee. So today we're going to talk a little bit about knee injuries, and in particular what happened to Cedric Wilson. Cedric Wilson is a wide receiver for the Dallas Cowboys who injured his knee on December 6th of 2019 in a game versus the Chicago Bears. As he was attempting to catch a ball during the fourth quarter, the ball was batted away by the free safety. As he turned to follow the ball, he suffered an injury to his left knee by a non-contact mechanism. He immediately fell to the ground holding his left knee, and he remained on the ground for some time. He was initially assessed by the training staff on the field, but he was able to walk off the field under his own power. He did not return to the game. He underwent radiographic imaging at the stadium, and an MRI was scheduled for the following day. So question number 1, how did it happen? So on this particular play, Cedric was running a wheel route, or an out and up against the defensive back. While Cedric and the defensive back were running down the sideline, the free safety came down from on top to close in on the ball. The free safety approached from upfield and batted the ball away to Cedric's left. There was very slight contact with Cedric's arm, causing his upper body to rotate to the left. Cedric continued to try to catch the ball, and he bent forward while he was still running. But the rotation caused his left leg to fall into hyperextension as it contacted the ground. Because his body was also rotating at the time of contact, his knee was also forced into varus, or in other words, bent with the knee away from the body, while it also went into hyperextension. As a result, he suffered a combined varus and hyperextension force on the knee at the time of injury. This caused a posterolateral rotatory injury to his left knee. And this just means that his left knee was injured at the back on the outside corner as a result of a rotational and extensive force. That's a mouthful, isn't it? Posterolateral rotatory instability. Say that 3 times fast. The usual mechanism for this type of injury is a hyperextension combined with a varus stress. And this just means that your leg is extended beyond straight and also bent to the side at the same time. This ligament injury is commonly associated with anterior cruciate ligament or posterior cruciate ligament tears, and is frequently found in knee dislocations where 2 or more ligaments of the knee have been injured. Although this injury mechanism involves an element of rotation, it can often be associated with single plane instability injuries. And it is very important for us to distinguish this injury from single plane instability injuries so that we can treat it appropriately. Now, there are several components to the posterolateral rotatory instability injury, and these include the popliteus tendon, which runs obliquely across the back of the knee joint, the arcuate ligament complex, and the LCL or lateral collateral ligament, and the lateral capsular ligament as well. Now, posterolateral corner injuries are graded by the modified Houston classification, and they range in severity from grades 1 through 3. Grade 1 injuries include less than 5 millimeters of opening on varus stress and less than 5 millimeters of rotatory instability on dial testing. Grade 2 injuries include 6 to 10 millimeters of opening on varus stress and 6 to 10 degrees of rotational instability on dial testing. And finally, grade 3 injuries, which include greater than 10 millimeters of opening on varus stress and greater than 10 degrees of rotational instability on dial testing. And believe me, that's a lot of opening and a lot of rotational instability. That's a wonky knee. Grade 1 injuries represent only a mild sprain of the associated ligaments, while grade 3 injuries involve complete tearing of the involved ligaments. So how is this injury diagnosed anyway? Well, with this particular case, we can see that Cedric underwent an initial evaluation on the field with the training staff. The team's physician performs both a varus valgus stress test to assess varus valgus laxity, as well as a Lockman to assess anterior cruciate ligament laxity on the field at the time of injury. A more detailed examination was likely performed in the locker room after he was off the field. It was reported in the news that radiographs that were performed at the field did not show any significant injury. And if this injury was simply a soft tissue injury which involved only the ligaments, this is what we might expect at the time of injury. An MRI, or magnetic resonance imaging, was performed the following day, and this will provide us with more information about the soft tissue injuries that may have occurred at the time of injury. Although there were no injuries that were noted on the x-rays taken at the field, there are some findings that can occur on x-ray that may indicate what type of injury has occurred. With a posterolateral corner injury, we may see abnormal widening of the lateral space on x-ray. In addition, we may also see an avulsion of Gerdy's tubercle off of the tibia or a Sagan fracture. A Sagan fracture is a well-known lateral capsular sign where there is an avulsion fracture off the proximal aspect of the lateral tibial plateau. And this is a sign that is also seen frequently with anterior cruciate ligament ruptures. Usually, this is a diagnosis that will be much more evident on magnetic resonance imaging, or MRI. MRI may show a contusion or bruise of the lateral femoral condyle, a distal avulsion of the LCL, where the lateral collateral ligament is torn off the fibula, or a proximal fibular head fracture or avulsion. This just means that there has been a fracture of the fibular head, or a portion of the fibular head has been pulled off by the arcuate ligament complex. In some cases, additional imaging modality might be required. If a dislocation has been suspected, then an arteriogram may also be required. An arteriogram is an imaging modality where radiographic dye is injected into your bloodstream so that we can take images to assess if there has been an injury to a vascular structure. So now that we know all of that, this leads us to our last question. What is going to happen next? Treatment for these injuries may be operative or non-operative, and the treatment type depends on the severity of the injury and the structures that were injured. Non-operative treatment is indicated for grade 1 injuries of the posterolateral corner or isolated mid-substance grade 2 injuries. Non-operative treatment typically includes immobilization in a hinge brace locked in knee extension for a period of approximately 4 weeks. This is followed by a period of progressive functional rehabilitation. Rehabilitation will require significant quadriceps strengthening, and eventually, after rehabilitation, the athlete will be able to return to regular activities and to sports. Operative treatment, on the other hand, can involve either a posterolateral corner repair or a posterolateral corner reconstruction. Repairs are indicated for isolated grade 2 posterolateral corner avulsion injuries. It is important to note that subsequent re-tear can occur in up to 40% of these repairs. Reconstructions, on the other hand, are required for grade 3 posterolateral corner mid-substance injuries or tissue avulsions that cannot be repaired appropriately or where the tissue is of poor quality. Rehabilitation after surgery requires immobilization in a hinged knee brace locked in extension for a period of 6 weeks with 6 weeks of non-weight bearing. This is followed by a period of 6 weeks where range of motion of the knee is restored. After 6 weeks, patients can begin weight bearing and they can start closed chain strengthening of the knee. Most patients can usually return to most activities in sports after a period of approximately 9 months. Where Cedric is concerned, the Dallas Morning News reported that he is expected to be absent from the team for an extended period of time. And over the next few weeks, we may or may not find out exactly the extent of his injury and what treatment was required. But at any rate, I can think it's safe to say that it's going to be some time before we see him back on the football field. I'm wishing him the best of luck, and I'm hoping that he will do well with treatment and be able to return to playing football after his period of rehabilitation. So there you have it. Today we've been talking about yet another NFL knee injury, the Cedric Wilson story. Be sure to like, share, and subscribe, and keep your eyes peeled for the membership options coming to this channel soon. And as always, that's been a word from Dr. Chris, not your everyday Ortho.
Just a flesh wound.